In orthodontic practices, the forces can be employed basically by two types. One is by orthodontic force and the other one is by orthopedic force. The orthodontic forces are those that are applied to the teeth by means of wires and other active components of a removable or a fixed appliance. And the force produced by these appliances are light and they range from 50 to 100 grams. And the orthopedic forces are those that affect the deeper craniofacial structures. And these are heavy forces of over 400 grams that bring about a change in the skeletal tissue. Thus, orthopedic appliances utilizes the teeth as handles to transmit the forces to the adjacent skeletal structures. Coming to the basis for orthopedic appliances. So in order to produce a skeletal change, consideration should be given to the amount of force applied and the duration of the force. What is the amount of force? It is heavy force of over 400 grams. It totally compresses the periodontal ligament on the pressure side and causes hyalinization, which prevents the tooth movement. And these heavy forces are conducted to the skeletal structures to produce an orthopedic force. The duration of the force. It is the intermittent forces ranging from 12 to 14 hours a day are believed to bring about minimum tooth movement and maximum skeletal change. The most extraoral orthopedic appliances are worn around 12 to 14 hours a day. And increase in the duration of the wear results in increase in the dental effects than the orthopedic effects. What are the methods of application of orthopedic force? The orthopedic force can be applied with the help of extraoral apparatus, and this includes a headgear, it includes a face bow, J-hooks, and chin cup. Coming to the headgear. The headgear is used in orthodontics to modify the growth of the maxilla, to distalize and protract the maxillary teeth, or to reinforce the anchorage. They are the most commonly used extraoral orthopedic appliances. When the headgear is used for skeletal modification, heavier forces are recommended, and such heavier forces bring about actions on the sutures of the maxilla, changing the magnitude and direction of their growth. Mode of action and goals of treatment with the headgears. A headgear is intended for use in growth modifications, and it's designed to deliver an adequate extraoral orthopedic force to compress the maxillary sutures, modify the pattern of bone apposition on these sides. Although the posterior and superior extraoral orthopedic forces primarily are intended to inhibit the anterior and inferior development of the maxilla, they also inhibit mesial and occlusal eruption of the maxillary posterior teeth as well. The goal of this treatment is for the restriction of the maxillary growth to occur while the mandible continues to grow forward an adequate amount to catch up with the maxilla. And this force needs to be sufficient magnitude, applied in an appropriate direction, and delivered for an adequate length of time during the period of active mandibular growth for this to be a positive treatment prognosis. Although the headgears can be effective appliance in the treatment of variety of class 2 problems, the most ideal indication for the use of extraoral force in the correction of skeletal class 2 malocclusion is with anterior posterior excess. Another indication for the treatment with headgear accompanying the maxillary excess would be normal mandibular, skeletal, and dental morphology because the extraoral force will minimally influence these features. And finally, the ideal circumstance for use of headgear must be one where there is continued active mandibular growth, primarily displacing the mandible in a forward rather than in a downward direction. Coming to the components of the headgear. The headgear assembly has three main components. One is the face bow, second one is the force element, and third one is the head cap or the cervical cap. What is a face bow? It's a metallic component that helps in transmitting the extraoral forces onto the posterior teeth. And the face bow consists of an outer bow and an inner bow and a junction. The outer bow is for the extraoral attachment, which is soldered to an inner bow that is attached intraorally to the maxillary first permanent molar bands. The outer bow is made of 1.5 millimeter stiff round wire and is contoured to fit around the face. The outer bow can be short, medium, or long. In a shorter outer bow is lesser in length than the inner bow, and in the medium outer bow, length is equal to the inner bow, and longer outer bow is longer than the inner bow. This is the force attached to the molar tube soldered to the Adams clasp. The distal end of the outer bow is curved to form a hook that gives attachment to the force element. The inner bow is made of 1.25 millimeter round stainless steel wire and contoured around the dental arch and the molars. The inner bow is inserted into the buccal tubes fixed onto the maxillary first molars. As stops are placed on the inner bow mesial to the molar tubes to prevent the inner bow from sliding too far through the tubes. The junction is rigid solid. The junction is the rigid joint between the inner and the outer bow. It can be simple soldered, wire wrapped, soldered, or welded joint. The junction is placed at the midline of the bows. When asymmetric forces are needed, the joint can be shifted from the midline. Face bows are available commercially and they can be obtained as standard face bow with or without cusp hooks and protective caps for the ends of the outer bow. The outer bow length is variable. Here the stopper loops can bend into the inner bow or stopper screws can be used. Face bow with stop loops. They are available with or without cusp hooks and with protective caps to the outer bow ends. The outer bow is of medium length. Force is applied from the headgear or the neckband via the elastics to the outer bow and is transmitted to the teeth and the jaws. Coming to the J hooks, it is an alternative method of applying the extraoral force by engaging J hooks to the removable appliance. This is not suitable for retracting the buccal segment as it is attached in the region of the incisors. This is an excellent method of reinforcing the anchorage. J hooks can be engaged to the helix incorporated in the modified label bow or onto the soldered hooks of the label bow or to that of fixed appliances in the region of the incisors. The types of force used is directed upwards so that the appliance does not get displaced. And the J hooks and occipital pull headgears can be used with the removable and fixed appliances since the direction of the pull is upward and distally directed. Along with the vertical pull headgear, they can be used to intrude the upper anterior segment. The force used is approximately about 200 to 400 grams per side. The ends of the J hooks should be bent and provided with protective caps. They should be firmly engaged to the extraoral appliances so that it does not slip out and cause any injury due to elastic pull either to the patient or to the children who are playing along with them. The force element. The force element is that part of the assembly which provides the force to bring about the desired effect. This may comprise of springs, elastics, and other stretchable materials. The force elements connects the face bow to the head cap or to the neck strap. The head cap or the cervical strap. The appliance takes anchorage from the rigid bones of the skull or from the back of the neck by means of a head cap or neck strap or a combination of the two. The selection of this depends upon the individual patient needs. Selection of the headgear. There are three major decisions to be made in the selection of the headgear. First one is the headgear anchorage location must be chosen to provide a correct vertical component of force to the skeletal and the dental structures. A high pull head cap will place a superior and gentle force on the teeth and the maxilla. Cervical neck strap will place an inferior and distal force on the teeth and the skeletal structures. When the head cap and the neck strap are combined, the force direction can be varied by altering the proportion of the total provided by each component. The choice of the headgear configuration should be based on the original facial pattern. The more the excessive vertical growth is present, the higher direction of the pull and vice versa. The second decision is how the headgear is attached to the dentition. The usual arrangement is a baseboard to the tubes and the permanent first molars. Alternatively, a removable appliance can be fitted to the maxillary teeth. Alternatively, a removable appliance can be fitted to the maxillary teeth and a baseboard attached to the appliance. This appliance can take the form of a maxillary splint or a functional appliance. This particular approach is particularly indicated for children with the vertical excessive growth. And finally, a decision must be made as to whether bodily movement or tipping of the teeth or the maxilla is desired. Since the center of the resistance for a molar is estimated to be the middle root region, vector forces above this point result in a distal root movement. Forces through the center of resistance of the molar causes bodily movement, and vectors below this point should cause distal crown tipping. The length and position of the outer headgear bow relative to the center of resistance along with the form of anchorage determine the molar movement. Effect of the headgear to the maxilla. The direction of the force must be compatible with the vertical relationship observed in the patient. A distal inferior direction of the headgear force will restrict forward maxillary growth but will allow or accentuate downward growth. If the mandible is rotated downwards and backwards, this will nullify most of the forward mandibular growth that reduce the classic relationship. On the other hand, distal and superior headgear force will limit vertical maxillary development and should not be used on a patient who has short face in conjunction with a classic jaw relationship. Coming to the biomechanics and principles in the use of headgears. Headgears, they have the ability to move the dentition of the maxilla in all the three planes of the space. The following factors should be considered when planning the use of headgears. One is the center of resistance of the dentition. A decision should be made as to whether bodily movement or tipping of the teeth is required. The center of resistance for a molar is usually at the middle root region. Force applied through the center of resistance of the molars result in their bodily movement. If force is applied below the center of resistance, it causes a distal crown tipping, while if it is above the center of resistance, it causes distal root tipping. Center of resistance of the maxilla. The center of resistance of the maxilla as a whole should also be considered when planning headgears. It is believed to exist at the posterior superior aspect of the zygomatico-maxillary suture. Under clinical conditions, the center of resistance of the dental arc as a whole should be considered. This is located between the roots of the premolars. Forces passing through the center of resistance of the maxilla produce translation of the maxilla in a distal direction, while forces passing above or below this point causes a rotation of the maxilla. The point of origin of the force. The headgears derived anchorage from the occipital region of the cranium or the cervical region. Occipital headgears produce a superior and a distal force on the teeth and the maxilla, while cervical headgears produce an inferior and distal force on the teeth and the maxilla. Thus, an appropriate point of origin should be selected based on what type of tooth and the maxillary movement would be beneficial for a patient. Point of attachment of the force. The point of attachment refers to the hook present on the distal end of the outer board to which the force element is attached. It is possible to alter the direction of the force to the maxilla and the maxillary dentition by altering the point of attachment. This can be done by varying the angle between the inner and the outer board. Coming to the types of headgears, based on the site of anchorage, headgears can be of three types. One is the cervical headgears, occipital headgears, and a combination headgear. Cervical headgears, these headgears obtain anchorage from the nape of the neck. Cervical headgears cause extrusion of the maxillary molars, leading to an increase in the lower facial height. They also move the maxillary dentition and the maxilla in a distal direction. These headgears are generally indicated in low mandibular angle cases, as an increase in the lower facial height would be beneficial in such patients. It is important to consider the relationship of the line force to the center of resistance of the maxilla and the upper dental arch. If the line of the force passes through the center of resistance of the maxilla, no rotation of the maxilla occurs. However, when the line of force passes below the center of resistance of the maxilla, we can expect a clockwise rotation of the maxilla. Similar consideration applied to the dental arch. Occipital headgears. These headgears derive anchorage from the back of the neck, back of the head. This type of headgear produces a distal and superiorly directed force on the maxillary teeth and the maxilla. Combination of headgears. In this type of headgear, occipital and cervical anchorages are combined. When the force exerted by both are equal, a distal and slightly upward force is exerted on the maxillary dentition and the maxilla. By varying the proportion of the total force derived from the head cap and the neck strap, the resultant force direction can be altered.